Again, I'm just very delighted today. I'm excited to welcome Charlene Laishley, who's an occupational therapist on the seating services team here at the Foothills, and Tessa Harris, who's also an OT, occupational therapist with the Adult Regional Seating Clinic at Care West and Alberta Health Services in Calgary. Welcome, you guys. Thank you for coming and sharing today. So you.
Awesome. Well, thank you for having me. You can see my screen and hear me and everything. Nice to see everybody. Yeah, I'll start. I'm Tessa. Charlie's just going to go after me. I'm just going to give like kind of an overview. I run the outpatient clinic, seating clinic here in Calgary. Just kind of an overview of the clinic, all the services available. Historically, we've, kind of gotten feedback from spinal cord community and other people that sometimes people don't know where to find us or don't know where to go. Obviously, things vary across zones, but there would be a seating clinic in every zone that you can access. And then obviously review all the factors that go into providing seating. Way more factors than I think lots of people realize. The amount of referrals I get for like specific things when we've not considered everything is really high. So I just want to review everything that we're looking at before providing seating. So the biggest thing, just to review, the seating clinic here in Calgary, we're at the Dr. Vernon Fanning Center in the basement. That's where we have our offices, assessment space. We actually are lucky in Alberta that Alberta Health Services still actually has fabrication shops in a couple of the zones. So they build things from scratch that the therapists that we can come up with that will help our clients. The clients that we see, we are busy here in Calgary. We see any full-time wheelchair user over 18 with moderate to complex seating concerns. Majority of our clients are from Calgary and area, but we see clients from Southern Alberta, Central BC. I've had some from Northern Alberta. Staff here is myself. I'm the occupational therapist. I've been here for 17 years. The physio Moji has been in seating clinic for 20 years. And Moji is actually one of the few people in Canada that has her RESNA ATP. So really lucky to have her. And then referral access. We also have our seating technologists that build the components for us, and then our admin. Referral access, if you need to find us, all of the clinics, I think in Alberta can be found on the Alberta referral directory. In Calgary, we're one of the maybe only, but we actually accept self-referrals from clients and families. You don't have to have a therapist to come see us. Our wait list, people will scoff when they see the 4 to 6 weeks for commercial, but that is actually true. Recent changes with like the provincial funder for equipment have really decreased our wait list for the commercial clinics. Our custom clinics where things need to be fabricated is definitely still longer. So some good changes that have happened there. Okay, so why do spinal cord injury clients come to us? Our job's definitely easier than the inpatient seating team. So we usually see our clients or the clients around 3 to 5 years post-discharge from hospital, and then usually every 3 to 5 years after that. Some clients we see more often if there's pain, pressure, positioning issues. We might even see them quicker after discharge from hospital, but that's kind of the standard. The easier thing for us is clients come in their current wheelchair. They have a much better idea of what's working, what seating components are working, what parts of their chair are working, and what really isn't working for them. So we don't necessarily have to start from scratch. It's a lot easier for us to kind of make adjustments and provide things that are different or the same if it's all been working well. So people come to us mostly if they need replacement equipment. So if you need replacing the seating components, you're needing a replacement wheelchair. Maybe you're not satisfied with your current equipment. The clients aren't satisfied. So positioning, comfort, function. Lots of clients will come to us with pressure injuries and how we can help with that. For seating components in Alberta, the major funder is the Alberta AIDS to Daily Living Program. So people will come because at our clinic, we have more access to higher levels of funding. That being said, you can still come to our clinic or to come get the expertise here with as many years as Moji and I have in it. Some people just choose to do that and will access alternative funding. And then lots of clients hopefully don't have a ton of issues, and we see them every 3 years just to kind of review things, make changes. There's always improvements and changes in different products. So that's something that we will look at as well. So what happens when we're looking at providing seating? Seating is definitely harder than it looks. I think there's so many factors that go into it. So the big thing is reviewing all the concerns that the client might have, reviewing all their current wheelchair seating components, pulling everything apart, looking at it. The big part is to, figure out what seating that you have, what's working, what's not working. Lots of times when we're reviewing the seating components with the client and try to determine if there's something that we can do to improve, we have to figure out where we're starting from. So we'll kind of pull the chairs apart, get all of the measurements, all of that. Sometimes what's maybe been in the historical chart isn't what people are using anymore. Lots of times they've borrowed it, they've bought it, they found it on Kijiji, their friend gave it to them. Lots of that in the spinal cord community. People end up with lots of different pieces of equipment, and they loan it to other people that need it, which is awesome. They've also maybe made adjustments to their own chairs and seating. So we need to take a look at all of that and just make sure that we're starting with all the proper information. Obviously the assessment starts with the concerns, but then we're looking at how the client's sitting in the current chair, reviewing kind of everything. Do they have an obliquity? Is there a postural concern? How's their balance? Are they able to sit with two hands free so they can do two-handed task? Just checking anything else that maybe they've added to their chair. Sometimes, people maybe with a lot of tone or spasticity that they've developed are like using luggage straps and belts to tie themselves into certain spots of their chair. So just different things like that we're assessing in the chair. Then we'll get the clients out of the chair and complete a full mat. So what that consists of is like full lower extremity range of motion, all the measurements, and a postural assessment. So just looking at, okay, once you're out of the chair, are we still seeing that obliquity? Are we still seeing that lean? Is your balance better? Is your balance worse? Sometimes it's the client that maybe has that pelvic obliquity or that postural, and sometimes it's the chair causing it. Different cushions might cause that, different things that we've put in the chair. Sometimes cushions are upside down, backwards, sideways. Parts of it have gone flat. So it's really important for us to have the client out of the chair and take all of those measurements. Those measurements also correspond, right, to what seating components we might want to provide, and then what wheelchair we might want to provide if that's what we're looking at. In our clinic, when we go to vendor site, we try and dry fit the possible seating components. So if available, and somebody's looking for a new backrest or needing a new backrest, looking at different options of cushions, if it's available, it's really awesome if we can install it that same day. So then we can, right, or dry fit it that same day to make sure that it's fitting properly. All of the equipment, if you just say you want a wheelchair backrest, that could be like 1,000 different backrests. So every manufacturer fits a little bit different, feels a little different. There's different heights, there's different widths. So trialing that behind the client really gives us a good idea, at least where to start. I often tell clients, you'll know if you hate it, you might not know if you love it. So it just gives us that really good opportunity to see if it's a possibility that it's going to fit. I know we don't like to talk about funding, but we do really have to confirm funding. These equipment's expensive. We have very reasonable provincial funding in Alberta, but there is things that are more expensive depending on the materials used. Things like people want carbon fiber backrests for weight. Sometimes those aren't going to be fully funded by the provincial government. But there is also all sorts of other funding out there. And then on the day, we like to install the component if it's available. So what that allows us to do, what we really like to do is trialing it behind somebody on the mat is one thing, but getting it in the chair is another. Making sure that your angles are optimized. It's not pushing you too far forward. It's not making the chair too tippy. It's actually doing what we expected it to do. Your balance isn't off. So if we do install those seating components, then we can fit the client in the new seating for the trial. For us, that's when our trial starts, once it's installed in the chair, and we let our clients trial the components for at least a week, if not longer, if available. If they need a little bit longer and we feel that equipment will be looked after during that time, then our vendors here in Calgary are really helpful and will let us do that. Okay. This is a weird slide. I know it's like, what is a seating component? But you'd be super surprised when people come to clinic that everybody just thinks all that's available is like a backrest and a cushion and maybe a headrest, because that's what they've seen. There is so many different seating components available. Pretty much if you can think of a body part or think of some type of support you need, it exists. So we have, of course, the common ones, headrest, backrest cushions that you see. But we also have, there's multiple types of trunk supports, multiple types of pelvic supports. And we're talking about supporting the pelvis laterally. You can support the pelvis like from underneath the pelvis with a cushion, and then also like pelvic straps, all to do that. Knee supports, whether you're providing adduction or abduction to decrease some of the tone. Sometimes you're even using like an anterior knee support to help if you're in a standing chair or even to help with sliding. Multiple types of foot supports, upper extremity supports, including trays, arm troughs, and then positioning belts to the right feet, shin, pelvis, chest, even head straps if somebody absolutely needs it. And within all these options, there's multiple manufacturers, multiple materials, and multiple hardware options. So when we're looking at all of this list, I just want people to think, okay, I'm having a problem with my leg, my feet falling off my power chair. You can come. There's always a seating component somewhere that can help with that. Or I'm really having a hard time with my knees abducting and then my ankles going into version. There's something that is available out there. So I guess for that part, just don't be afraid to try and access all of those components. People are really surprised when they do come. We're like, yeah, we have something that we can help with that. We have this component that can help with that. Oh, look, we have this. Seating has been around for a long time, and the technology and how we attach things and the types of equipment and brands and how it looks have changed over the years, but the actual components of support have been pretty similar, right? Especially thinking of like an abduction pommel. Well, it's really its job, right, is to keep those legs apart. Yeah, the hardware's changed and maybe some of how it looks maybe has changed, but it's doing the same function. So there's lots of different things that are available. And here's the big part. So selecting all of the optimal seating components. So this is a big one, right? This is our main job. And when we're looking at seating components, really we're trying to match multiple factors. So of course, big one. What's the client's assessed needs? What's their concerns, right? Is it a postural concern? Is it a pressure concern? Is it a comfort concern? Is it none of it for the client? Maybe they sit really well and they just need their equipment replaced. So what are we trying to get out of the seating is the big one. And does it fit the client? So that's where we're taking the measurements, looking at all the supports and seeing how it fits the client. Awesome. We look at, all the different backrests, all the different headrests. We're like, yes, this one fits. Okay, well, now they have a manual wheelchair. They have a power wheelchair. Does this backrest that we love that fits the client, does it fit the chair? Is this a possibility? Or do we have to choose something different with slightly different hardware, maybe a different manufacturer that the backrest can fit a little bit better? And then if those two things meet, and yes, we found something, okay, it's going to fit the client, it's going to fit the chair, we're somewhere where we can start for trial. Is the client still able to transfer? That's a big one. So lots of our manual chair users that do independent transfer, it's a common thing that if maybe they need some more postural support, they need more lateral support, and you do all of that. You're like, okay, I got your hips in the middle, everything. And you're like, okay, I just need to check your cushion again. Can you transfer out of the chair? And they're like, no, you've put all the support in here and now my butt hits it on my pivot transfer and I can't get out. And if I can't transfer, I can't toilet and I can't do this and I can't do that. So then that becomes, okay, we have to change something in our seating because we're not meeting now that factor. Even with clients that are mechanical lift transfers, we really have to take this into consideration, the amount of lateral supports and headrests that have been ripped off of chairs and ripped off of seating system from getting caught on lifts. The slings is really high. We're fixing them all the time. So we really just have to make sure that we're educating our caregivers and whoever's doing that transfer to try and minimize that and not provide maybe seating that is like so tight that that's going to be a problem. Another big consideration is lifestyle consideration. I get referrals all the time that say client has a pressure wound, needs a rojo. And I'm like, yeah, that's great. We'll have them come in. We'll look at everything. I'll tell you, a foam cushion will pressure mat better than a flat rojo. Some of those cushions that really need a lot of maintenance, we really need to consider lifestyle. So if somebody's a smoker, probably not a great cushion. If somebody has cats that sit on their wheelchair and like to need, probably not a great cushion. If somebody doesn't have like consistent caregivers or family members that can check the air inflation in some of those cushions or maintain some of those cushions that need it, probably not a great option. I would say in my clinic, the amount of air cushions that I check, half of them are probably flat. And that's an $800 cushion under somebody's bum that's not being used appropriately. I'm sure there's a research study there somewhere that, right, that I check majority of these cushions and I'm always adding air. Even if you do get a hole, are you able to fix it? Lots of vendors in Calgary will fix it for you for cost, always. So there is charges for that. So maybe we've figured out the client's assessed needs. We found a backrest or a cushion that's going to work, fits the client, perfect, fits the current chair. Yes, they can still transfer. No, they don't smoke. Maybe we've collected all of those things. Okay, good. Is it available for trial? That's another one. There is so many seating products out there that are vendors, at least in Calgary, and I'm sure it's provincial wide, only carry so many things, which is understandable from them. I totally can get, you can't have 20 16 wide backrests. It's just not feasible. They will be able to get things from manufacturer, but sometimes those one-offs or those really specific components aren't available necessarily for trial. And, lots of the vendors will order it in for trial if you think you're pretty sure on it. But it's also something to just watch and make sure, like, it's sometimes hard because without trialing it, how do you know if it's going to work? So that's another factor. And then trial success. So anytime we put seating under or on or with a client, we of course trial it for at least a week. We like people to take it, to use their chairs, use their seating as they would in their real life. So were they able to function on it? Were they able to do their transfers? Were they able to pick the things off the ground, walk their dog, reach into their fridge, cook, right? Caregiver for children, whatever it is, we want to make sure they can do all of those functional tasks. Was it comfortable? That's one that's also important. You're sitting in it, the clients are sitting in it, it has to be comfortable. I can, right, force people into a position that's not comfortable and it won't get used. Things will get taken off. Aesthetics, it's also very important. This changes too, right? Like maybe initially when people are an inpatient in hospital, they need a lot more support. And as they come out of hospital and they get stronger in their upper extremity and their transfers are stronger and everything, they maybe want less seating. They want people to see them and not the seating components. So aesthetics is really important. And kind of along that same line is acceptance of that too, especially for our aging spinal cord population. I have lots of clients that really want minimal support. And as we age, as we know with spinal cord injury, you might need more support. And can you accept and are you ready for that? And that's fine too. Our clinic, we try and be like really holistic in that manner of like, call us when you're ready. You can try it. Didn't work for you. Not ready. No problem. Put something back, change it, right? Try something different and call us when you're ready. So the acceptance from the client end is also really important. That all goes in with that trial success. So if we've managed to meet all of those things somehow, or maybe we haven't and we've had to weigh the pros and cons. What's number one right now? I was in a symposium, an international seating symposium once, and then there was a panel and there was a SLP and a respiratory and an OT and a PT, and there was a large discussion on what was the most important. And at the end of it, breathing one, respiratory one, breathing's number one. So just to go through all of that and see, okay, right, it works for all of these things. Yeah, maybe it pressure mapped better, my wound's healing, but that's not my priority. Something else is my priority. Or my posture is way better, but I can't lean to pick up something off the ground. I live by myself. If I can't do that, right, then that's not I can't use this backrest. So weighing the priorities to try and meet as many of those things as we can is definitely a goal. Funding. Always, yeah, we have to always talk a little bit about funding. Maybe you've met all of these things and you get to the end and you're like, oh my gosh, I can't fund this. how can we make this happen? So there's always alternative funding options. Alberta Aid Living is a great funder for seating components. Funding also rolls into eligibility. So there is some eligibility requirements with any funding program, including ADL, WCB, insurance. They usually have some type, NHB, veterans. They usually have some type of eligibility for, okay, we expect your seating component to last 3 years, and then you can get a new one. We expect your wheelchair to last this long. So just to pay attention to that eligibility factor as well. It shouldn't be a deciding factor by any means of the funding and eligibility. There's always, right, room out there to find funding and to deal with that eligibility if it's an issue. And then looking at a chair too, and you can talk about seating forever, but the main device is the chair and how it's going to fit and how it's going to work. So I thought I'd quickly talk about that. Lots of times in my clinic, we have clients that we're seeing and we do their new chairs. Sometimes, you know, if they're not followed in community by a therapist, then we'll definitely look at that. There's so many different chairs, right? If you think of it as a big hierarchy, you're starting like at the top, manual power. And then within that, you're like, okay, do we want a manual tilt chair, a manual rigid sports chair, or a manual folding chair? And then within the power side, we're looking at, do you want a scooter? Do you need just a regular rehab power chair? Or do you need a power chair with power positioning? So it really falls down into that. And to select all of those things and to find the right fit is a lot. So it's really important and to make sure that we're like reviewing all of those options and selecting the appropriate piece of equipment for that client. A big thing with the style of chair that you're looking is how it's used, accessibility and like vehicle, right? We have lots of clients that, right, yeah, maybe they should be in a power chair with tilt, but they're like, no, I don't want to use Access Calgary. I don't want to spend $80,000 on an accessible vehicle. My family member could still transfer me into a vehicle. So I want to stick with just a folding manual chair so I can get around, because that's a priority to me. So I think that that's something to consider when we're looking at environment and accessibility and chairs and seating, is how it's going to be used and what the priority is for the client. Obviously, when looking at chairs, they come in every size you can think of. I don't work in pediatrics, but they're down to like the 10 and 12 inches. And I think the largest here I've ever done is, I think, 38 inches wide. So, and everything in between, right? So the sizing is whatever the client needs for that, and whatever will fit in their environment, and whatever will fit their seating. Obviously, there's different weight capacities on the chairs. Trial availability is a big one again, especially for like maybe the rigid manual chairs. You might be a really specific size and you want to trial a specific chair. Well, that exact size might not exist, especially when you're dealing with some of the chairs. You're at least looking at 1-inch increments, but some of the chairs are actually measured in millimeters. So you can really fine tune what you want. I know when I order my demos, I order 17 by 17, because I just think, okay, well, if somebody needs a 16, they can trial a 17. And if somebody needs an 18, they can trial a 17. So that's how I do mine. So trial availability when we're looking at chairs is it's harder for sure, because it's, especially when you're selecting a rigid chair, and I'm sure lots of users that are listening in this presentation can understand that you might have to trial something that's not the exact size, and that's okay. It gives us a really good idea of other things, but you will sometimes, right, have to look at that. Eligibility, quick blurb on it. Right, 90% of our people that I see in clinic are funded by Alberta Aid Daily Living. They've really done a focus lately on primary chair. So they want to know which is your primary chair. And that's what they fund. So if you're getting a power chair through ADL, that's what they're going to fund. And your backup, they'll fund a backup chair, but you're not getting a sports chair. You're getting a recycled chair out of the program, and it might be a manual tilt chair or a folding chair. But just something to consider. It's not perfect. It's definitely hard. I have lots of clients that, especially in rural communities, where maybe they're in a power chair because that's what they need, and they use it almost like their vehicle from right, their home to the grocery store, but then when they want to go to somebody's house, they like to be in a manual chair because not everywhere is accessible. So it's definitely tricky. So just to be aware of, right, what people are eligible and to really put a maximal funding into what's going to be the primary chair. I think that that's super important. Okay, last one. No questions yet because Charlie is going to present now for the next little bit. Quick review though, just want to get across that providing seating and prescribing seating, it's a more complex process, I think, than people realize. Multiple factors to consider. And we have to try and find the best of the client's priorities, clinicians' priorities, and try and all meet in the middle. Another thing to quickly say, you know, I talk about eligibility and I talk about funding, but like our clinic here, we're here to help. So anybody in Calgary area, if you're ever struggling, we've worked here a long time. It's an old building. We have lots of storage. We have stuff around. So, right, if somebody calls me or a client needs something, you will never go without. We have stuff around all the time. So I think that's just important to realize that. Feel free to connect. And yeah, I'll pass it over to Charlie to do an inpatient seating.
Hello, everyone. Can you hear me? I'm hoping.
Yes, we can hear you.
Perfect. Thank you.
You only have
okay.
about 5 minutes left, though.
That's fine. I'm going to wing through this because Tessa provided very comprehensive information about all the seating. So here, next slide, please, Tessa. So here we run a little differently than in the community. We have occupational therapists, physiotherapists, and seating technicians. We have about 4 to 5 vendors that come into the facility to help us with equipment trials. And we service the people in the hospital, primarily on Unit 58, but we also do consults to the rest of the hospital for people that are requiring complex seating. And this slide will be quite quick because we've talked about most of it already with the other presenters as well. I come from it a little bit different perspective, is that people are new in their injury. So it's almost an educated decision on where you think the person is going to end up in the next 3 to 5 years. And it's an educated decision with a lot of team input and physician and physiatry input to get that kind of general feeling. Funding here is a little bit different as well. We do look at ADL, but people that have a new injury, they tend to have a little bit more funding available because of private insurance or Section B, or maybe it's a WCB claim. So we have the help of social work to help look into the details on that. So luckily enough, we can typically get what we need from the hospital based on their funding. Next slide. Okay, so everyone's heard of, well, diagnosis and prognosis. So team approach, wondering where they're at, where they're potentially going to go to, and the level of injury, complete versus incomplete. This is quite an important one because recovery, you know, for incomplete can look very different, and in fact is very different than a complete injury. So looking at the American Spinal Injury Association impairment scale, the physiatrists do that over on the acute side, but it can also be updated while they're here on Unit 58. Next slide. Other assessments that we look at is the muscular part, innervation, tightness, and tone. We've already talked about spasticity and tone. Also looking at previous injuries. If they're going to be a manual wheelchair user, do they have rotator cuff injuries? Do they have carpal tunnel? Has there been other injuries that might influence their primary means of transportation, which is now going to be their arms and shoulders? And also we have to look at structural changes over time. So Tessa did talk about the MAT assessment where we look at pelvic obliquities and spinal changes. Gravity is really hard on the body and we try and support. And this is also one thing that she had mentioned where, you know, sometimes we provide a little bit more support trying to reduce the structural changes over time. And at times the end user, the wheelchair user, wants less because of aesthetics. So trying to find that happy medium to allow still function and support. Next slide. This is just a general looking at sitting balance. I guess you can just read it. So low thoracic, if we're looking at a T9 to T12 injury, we tend to have a really good hand function. The higher the injury, the more the arms and the hands are involved in seating and positioning. So we want to try and accommodate what they have so they can still use their arms, be functional in whatever task they want to do, and not have them holding on to the chair for their main support. Next slide. Of course, then we look at skin integrity and pressure source. So we talk about offloading. Are they able to offload? The quality of offload, the quantity of offload, and also a person's buy-in. Is it important to them? So they're taught how to do it. They know how to do it, but can they find time in their life to do it? Because it's one more thing to do. Also looking at the Braden score. It's something that we learned way back in school. It seems not that important, but it's actually a really good indication of kind of how they're going to be for their skin, their moisture. Are they sweaty? How's their nutrition? And transferability, which then relates to friction and shear when transferring to the wheelchair or out of it. I don't think I'll talk about this because Raj covered that very nicely to start with. Pain management, medications, preferred position out of bed. Can we get them upright? What do we have to sacrifice to get a person sitting supported that they can use their arms and not feel like they have to hold on? Back to transfers, looking at ceiling lifts, portable lifts, sliding board, or how is their transfer? Because there are some unconventional transfers in the community, and just because we think we know how they transfer doesn't mean that we do. And Tessa alluded to that as well. You get them in the chair and positioned, and sometimes they just can't get out of the chair. Environmental factors. So looking at discharge location. Are the home visit is completed by the OTs in the community or by our OTs on Unit 58. We get a good sense of what's happening in their home, where they're going to, and will the chair actually work for them? We do have the luxury of having rec therapists here who work with them on transportation and doing community visits to see how they actually are able to maybe use Access Calgary or access the C-Train. Next slide. So we are client-centered here in that we talk to the person, see what their hopes and needs are. They're so early in their new change in lifestyle that sometimes it's a little bit of a give and take. We need to get them in a chair before they leave the hospital. So sometimes we're a little bit more restricted on timeframes. We also look at getting equipment that is somewhat modifiable because they're still changing when they get discharged, whether they're discharged to home or discharged to assisted living or wherever that might be. We may have to compromise some of our best posture to achieve the function. And also, like what Tessa was mentioning, is we need to think of 3 years for seating, 5 years for a wheelchair. So looking down the road, we can't look at just the next year. What's that going to look like? We need to look down the future as well as safety. So if they are getting into a power chair, are they safe in the community? Are they safe around people? Are they a risk? And people might know Kathy Flaman. She was a previous seating clinic therapist. And I did steal this from her, and she obviously took it from an article. But I think it really runs true. So without skin protection, one cannot sit. Without postural support, one cannot maintain alignment. Without comfort, client-centeredness is lost. Without mobility, one cannot function. And without function, one cannot live. And in conclusion, so all factors, it's a bigger picture look from the hospital. And we try and make educated decisions based on future needs, but also future wants. Does the individual want to go back to work? Do they want to go back to school? Are they raising a family? So we try and look at the big picture and try and get equipment and seating that will allow them to reintegrate back into their environment.
Thank you.
Yeah, no problem.
Thank you so much, Char and Tessa. Again, even though I've had my injury for a long time, learning a ton, and you're right, there's just so much involved. So now we have some time for question and answer, and just gonna scan here the Q&A. Again, I did see a couple hands raised. I encourage you to use the Q&A box at the bottom here. I do have one question here for you guys. What would you say, what's the best cushion if someone has a pressure injury?
So many factors, right? You really can look at, there's kind of two ways of cushion. There's pressure redistribution cushions. So that's where you're more in like your air cushions. There's multiple types of air cushions even within that. And then you're looking at your offloading cushions. So that's more like your ride custom cushions where you're offloading. Ideally, you really have to figure out where that pressure injury came from. Obviously the pressure in the chair isn't helping if somebody's sitting, and we can help with limiting that pressure. But if the pressure injury came from somewhere else, another component that they sit in, or maybe an injury like a fall or something, then we can do our best in the seating, but sometimes that constant pressure isn't going to necessarily heal that wound. So yeah, multiple factors to consider, but there is kind of those two schools of thought of pressure redistribution and then pressure or offloading, depending if, right, what's going to work for the client.
Okay, thank you. I have a question from an anonymous attendee. How long should the cushion be? Should it cover all the distance marked K on the first slide for your picture?
I'm not going to go back and look at that slide, but ideally you want space between the front of the cushion. You want to have like full coverage. You don't want your bum hanging off of the cushion at the back, and you want reasonable coverage all the way to the front. It depends what type of user you are. So some of our independent rigid frame spinal cord users tuck their knees, right? Or tuck their feet behind their knees. So they would go with a shorter cushion and have that depth actually of the cushion really close to the back of their knee, where some of our other spinal cord clients that maybe use power chairs will probably have about 1 to 2 inches of space there. It depends on the type of cushion too, and the size of your chair and the length of your leg. Sometimes, right?
Yeah,
if somebody has a really long
variable.
leg, yeah, it's very variable. So, but yeah, you don't want much more than 2 inches unsupported thigh because that will affect your pressure.
Have another question here. What is the recommended offloading duration time and frequency for clients seated on the in a wheelchair?
So the hospital, we do say 2 minutes every 30 minutes. So to either side, forward, or completely off every 30 minutes. So holding it for 2 minutes all day that you're in the chair.
Sure. Do you tend to steer away from air cushions for spinal cord injuries for stability or postural reasons?
I don't steer away from them because we can get Rojo Quattros, which then limit the airflow between the cells. So they are a little bit unstable, but it depends on the style of transfer. What would you say, Tessa?
Yeah, and I think like there's lots of air cushions that have air and protect like your ITs and your coccyx, but then firm at the front first. So if you are pushing up on that transfer, that's a really good in-between that gives you both the stability and the protection. If you're using a full air cushion, there's especially a Rojo, and you transfer on this and push off on the same spot multiple times a day, that cell of that air cushion is going to wear out and you're going to have problems. So it really depends on transfer style. For that. But yeah, we don't steer, I don't steer away from them at all. I would say probably most spinal cord users I see are on some type of air. maybe not always ROHO, but some type of combination, just because pressure is such a problem.
Okay, and it looks like we just have one last question here. Are there any typical or expected postural changes with aging spinal cord injuries, for example, 20 years post-injury, and recommended seating interventions to address those?
Yeah, I find the longer post-injury, for sure you'll need more postural support, especially for our higher level injuries. You definitely need more postural support. Our lower level injuries, right? They have a little more muscle tone, a better trunk control. But there is some studies showing like even just in sitting, you won't have the muscle mass under your bum anymore, right? And they've done imaging of that over years. So even if you do have perfect posture, 20 years post of sitting, our bodies weren't designed for that. So you'll definitely see less muscle mass under your bum. So you probably would need something that has better pressure relieving qualities. And then obviously for our higher level injuries, yeah, as you age, then we're dealing with arthritis, other things too, and different things that have happened over time that maybe you've compensated for function, and now you have to support that better. So.
Well said. Thanks again, guys, for coming presenting on seating today. Really appreciate
Thank you very much.